Pledge of allegiance.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Well, I don't know.
Well,
Okay, we'll let you know.
thanks for coming.
Do we have any public comment? No?
You want to make a comment?
Hi,
Yes. Can-
my name is Ava. I currently work here as a unit secretary and a CNA, and I'm also a part of the first Lakeview cohort for the nursing program here.
Welcome.
Thank you. And I just had some questions about potential employee funding for that. I know there's been funding 3 years ago for it, and then of course COVID happened, and then
Are you talking about scholarship?
yes, through the hospital. So I was just wondering if there's a plan set in motion for that. I know the two of us that are in it, in the cohort this year, are more than willing to do anything, not do anything, but like necessarily sign our life away. Necessarily like sign our life away to maybe get some help from the hospital before school actually starts. September 26th is our deadline.
So Ava, I'm sorry, we haven't quite got that finalized. The board has looked at our policy. They've looked at a lot of things, and actually that's part of our agenda tonight, is to talk about coming up with a plan. So we hope to have an answer for you certainly before school.
Okay.
All right. When does school start?
September 26th. So 25 days.
All right.
We are very
Horse to the fire.
Okay.
Yep.
Thank you.
Yes.
Okay, well, thank you, Eva. Okay, anything else? Okay, moving on to the consent agenda. We had a chance to read the minutes and the corrected minutes.
So if I could address that just as a couple things. On our agenda in June, we needed to do a couple things. One was to approve the budget, because that has to be approved before July 1st. Second thing is we have to have the resolution to approve the that budget, which allows us to, or allows the county then to tax all of the residents. We approved the budget, so we need to change the minutes to reflect that. We just didn't, it was on the agenda, we did it, but it didn't state that in the minutes. And then because we failed to bring up the resolution, even though you signed it, both you and Gerald signed it, we didn't have in our records that we had actually approved the resolution. So we're going to ask you to approve the resolution.
So would you call that the amended minutes?
So in what I thought we had sent out to you, and if I didn't, my mistake. At the bottom it says the September 1st, 2022 addendum to June 2nd minutes that was originally adopted, or approved rather, at the July 7th, 2022 should be meeting, to add added information regarding the approval of the fiscal year 2023 adopted budget resolutions noted under the agenda item 4.8. So it was on the agenda. The resolution was discussed, then John Shine, I guess we did approve it. John, you moved to approve it. Gerald seconded the motion that was unanimously approved.
So if we move to approve the amended minutes, is that what we're looking for?
Yes, we need to approve the amended minutes.
I so move that we approve the amended minutes on resolution.
On the resolution to adopt the budget.
To adopt the budget.
Okay, sorry. Okay, been moved and seconded to approve the amended minutes to include the adoption of the resolution. All those in favor?
Aye.
Passes unanimously.
Sorry about that, we just while we were trying to get things done, between
That was an
Susie,
oversight on my side, gentlemen, sorry.
between Susie and I, sometimes that we lost it. But thank you.
Okay, so now we move to the regular consent agenda, which included those June 2nd minutes, but the regular August 4th minutes, and then we have the calendar. So
Okay, you can move on this one.
I move we approve the consent agenda as given.
By second.
moved and seconded to approve the consent agenda as presented. All in favor?
Aye.
Passes unanimously. So, Mr. Ed, you're up.
Yes, all right,
Give us some bright spots in the financials.
absolutely.
That's a stovepipe, all right. Holy mackerel.
So this is the financial report for July 2022, which is our first period of the FY '23 fiscal period. Next slide, please. Okay, start off with patient count. Acute in '23 is 398, an increase of 73 over the previous year. Clinics 23 is 1770, a decrease of 436 over the previous year. And that's really drilled down on that, and that's due to provider absence and vacancies right now.
Okay.
While the other folks are, working as hard as they can, truthfully.
Well, I noticed that, the 398 is a pretty high level for acute, and wanted to give a little shout out to the people in acute for the work they're doing, and the, particularly in ER and obstetrics.
Yes,
They-
very busy.
You guys were busy, so thank you, it's looking good.
Yes, we appreciate it, thanks.
And I apologize too, we're gonna kind of try to get the stats as more of a, like a dashboard kind of where it rolls in right into this, but it's, in the interest of time, we just waited. We'll roll it out next month that the finance committee approves. Outpatient services, 5,233, an increase of 248 over the previous year. That's really physical therapy and occupational therapy. It really kind of stepped up a lot. We have a full schedule. Overall, the month of July, there were 7,400 visits, which is 115 less than this year, but if you think of the folks that are not with us this year, that's still very, very good. Next one. All right, for July, it was 4.6 million. It's an increase of 894,000 over the previous year. And we want to keep up this level and keep going. Next slide. For collections, from July, it was 2.9 million. It's an increase of 388,000 over the previous year. And something to remember is that there's a $500,000 deduction in that from Medicare. So, for the CARES Act.
Already taken or?
Already taken, and then this is the net, so,
Oh, so we actually did much better.
yes, correct.
Yeah,
And this, we've been.
we're still working with Medicare, trying to get that squared away,
Yeah, just as a,
500,000 a month.
as far as what I see in August is 673 was paid to that same fund. So that leaves us with just 527 in September to pay, and we're gonna.
So no matter how much we ask for assistance to get that waived, it was, they thought it was a nice idea.
They just stalled us out till it's done.
No, and the thing to remember is in the first year repayment, it's 25%. That's not such a big bite, but now we're in our second year as of March, and it's 50% from the Medicare income. So,
Puts a big hurt on cash flow for sure.
it absolutely does. Just wake me up when September is. Thanks a lot. Days cash on hand. For July, we had cash on hand of 19 days, 81 less than this time last year. And just to kind of
I thought you adjusted that number.
No, well, basically what is, that number is based on the trailing 12 months of expense, where it's not our true expense today. So that number actually adjusts.
After 30 days.
Right, correct, it does, it does. And with our current spend now, with our current income now,
I see what you're saying.
and it,
You know, if you look at the spreadsheet calculation, they use the last previous year.
and I think that's that's kind of a little bit, and I can tell you at the end of August, it's somewhere around 29 or 31. We were trying to drill into that today and get you a final number. And the other thing is to remember that there's $2.5 million that's restricted by both the board and as well as grants as cash reserves, so.
How many days is that for?
Somewhere between 35 and 45 total, but it's, I think what we have, the things that are coming into place that I'll talk about later on in this presentation, I think will come to fruition in August and as well as September. And then November is, we're all downhill skiing.
So we'll get the property tax proceeds.
Yes. Okay, for the monthly net income for July, I was trying to, didn't get to show you guys really a true picture, but for July we had 4.6 million in gross revenue, less revenue deductions at 985, which is that's a $300,000 increase month over month, as far as us being more diligent in what we're doing.
No, it's good to see that.
No, we're getting down to the 23, 25% revenue.
Correct. Yeah, I think we were at 21% for July, and almost as low, we're not closed out yet, but somewhere between 19 and 20 for August.
Do you think that's going to carry forward from here on?
Absolutely.
Okay.
Because we have the data analytics now, and like the hard work of these guys will be there for sure. Yeah, let's see, this one's probably a better one to look at. So, the thing I want to point out on this one really quickly is the 3.6, of course, we're 27,000 over budget in revenue, and our expenses for operating are 222,000 less. So that we are making a concentrated effort. The other piece too, the contract labor at 693 is not really a true reflection of what we're doing. It's just kind of an anomaly, and it's going downward. The other thing too to point out down at grant revenue, that 532 is for the grant, the burn grant for behavioral health. So that created a net income of 878, but if you take out the grant monies, it's still a net income of 391. So, yeah, for the first month of the year, we're 1-0, I guess. I looked at all the other hospitals within 200 miles of here, and we're the only one that's positive. So,
Well, that reflects from the increased census that we've been dealing with.
yes.
So now we just need to follow through on the collections on the three sets.
No, and that was the biggest thing too, is our write-offs are down 5% at least.
Mhm.
And it was 1% in August is what I found out today. About $9,000 is what we chalked up to bad work. So we're really getting a well working team.
Appreciation goes up.
For the balance sheet, nothing exciting here. Total assets of 42.3, total liabilities of 37, fund balance of 5.2. Able to reduce some liabilities, but we're still have a long way to go. And that's all I have for the Lake Health District report, unless there are any questions or anything else I could kind of speak to.
Well, we talked about this in the finance committee meeting yesterday, but I think our biggest opportunity is our billing office, and we've got $2.8 million in discharge not billed. That is cash that
Was already earned.
we provided the services, we just got to get our billing cycle faster.
that forces, the receivables are going up, and it just reflects that we've got to work in that area.
We'll get it done.
Okay, thank you. So, we're into Lakeview Gardens.
All right. So this is one of those ones that we're going to have greatness soon. It's just not there reflected yet in the financials. So I'll try to explain that as best I can. And before I go off that, I was going to say too, it should be noted too that the clinics have been profitable the last, 3 months in a row. So that's a huge deal. Okay, for Lakeview Gardens, gross revenue and long-term care, 185,618. Some of that is because some of the folks were over on Tori's side of the school, over here.
What is that?
They were in swing beds, or they were getting taken care of at a higher level. So that's why you see a little dip. It usually runs around 200, 225, but that's why it's at 185. In the out, 48,645, that's the highest it's been in a year. Now the revenue deductions, the 41,000, and that's something that we've been digging into, and I spent most of our time this week, is why we're having these adjustments like this. And I don't have a solid answer for that, but I've contacted the state and DHS and MODA, and we'll have an answer hopefully by tomorrow as to why that revenue deduction. If we go down through wages, there was an increase of wages of 25,000 in the month. But if you look at contract labor at 116,857, that's 155,000 less than the previous month. And you'll see it go even further down next month because Mickey was able.
Close the one house.
Yeah, and
So that's really awful.
the revenue deduction.
No, the 253 loss in 1 month.
Right. Well, and that's the thing is, and we cut 155,000 out of contract labor
But when did we close the one building?
in August.
So it was not
No.
before that.
And then the other piece of that too, the other expenses, that 49,756, that'll go away in October. That's the provider tax.
Oh, yeah.
Because our census is over 85% Medicaid currently. So,
This is the first time ever we've been able to do that, isn't it?
yep. And we'll take, I think it's full, if I'm not corrected, the census is 12 and 12, so we're gonna get there. This thing is on the verge of greatness.
Well, if we keep it, we got it full, hopefully we can at least break even.
Yes, and the other thing too, like, for example, the out, 48,000, 50,000 is where it tops out at pretty much for a full out. The part of that to remember is that for most of the year, it's been at 24,000, or 40, 50% capacity. So due to COVID restrictions. So this one's gonna turn it around here in the next couple months.
We're gonna hold you to it.
I appreciate that. Lake Health Medical Supply, revenue of 32, expenses of 28, which resulted in a contribution margin of 3,500. Not as their largest month because it's not that they're doing more business, it's what they were able to collect, is what we're showing here.
See a little dollar rounding there.
Yes. Get that fixed. So, and that's all I have for Goose Lake Medical.
Okay, any other questions? Thank you, Ed. And now we have the stroke information report.
Yes.
Review.
So, we're gonna talk about the stroke here and the stroke situation in Lake County. So the next slide. So, okay, so stroke is the number 5 cause of death and leading cause of disability in the United States. The last big research was done in '96 and showed that rural population are 1.45 times more likely to have a stroke in their lifetime compared to the urban areas population.
Why do you think that is?
Its mean amount of cases bigger in the, compared to population of, like, rates of the stroke is bigger. And the chance to get the stroke living in the rural area is higher. And in 2017, it wasn't a national research, it was more like selected states. But it was showing about the same results, that rural area, there is the higher risk to have a stroke. Practice of the stroke in the rural areas has multiple challenges, and it's a national challenges. It's geographic isolation, hospital resources, limited access to experienced medical staff. Not every have emergency medical services, shortage of neurologists, and limited technology. Well, we don't have all of them, but it's still, we're seeing the increase in the stroke situations. So the next slide. In Oregon, actually stroke is number 4 leading cause of death. And we pretty much, it's data from 2020 from CDC. And total amount of death in Oregon in 2020 was 2,200 patients.
How about Lake County?
Next slide. So here is the trends for the last 20 years for the Lake County. And the first chart is for the population ages 65 and older, Medicare population. The second chart is for ages 35 to 64. Till 2012, Lake County was showing a huge decrease in the rate. And starting 2013, we started to see an increase in the death rate in the stroke. Same from age of 65 and age from 35 to 64. Next slide.
To what do you attribute that?
I would say that amount of the stroke cases increase. But it's nationally, it's not just Lake County. Nationally, it was showing an increase. It was a huge decrease till 2010, and it was a program for decrease the death rate among the stroke. But it's showing nationally that it's increasing. It's not just Lake County.
Right. But is it diet, exercise?
We're gonna get to that.
Okay.
We're gonna get to that. And there is a less rate on the women and the higher rate for the men's from the Medicare population. Next slide. So here is actually stroke hospitalization rate for the Medicare population. You see national rate, state rate. For the long time we were lower, like twice lower than the state rate. And the last, starting in 2013, we started to increase amount of, like, rate of hospitalization per 1,000 Medicare patients. In 2 years, we didn't have enough amount of patients to calculate the rate, so it was the low. But next slide. So in the last 10 years, the average stroke patient rate for our Lake Health District stroke patients is showing, it's staying between like 69, 70, 980, but it's slowly increasing. Also, we start to see in more patients, like in more patients in between 55 to 65, and actually last year we saw 6 patients with an age less than 55, so stroke getting younger by 1 year, but we see in the also this situation. And next slide. So this is our all stroke patients, what we report to American Heart Association. We participate there Since 2013, our main goal is become a stroke-ready facility, and we were working on improving our response time. So state is growing, but we saw the huge increase in 2021, and currently we saw still a huge amount of numbers in 2020. That's why starting end of 2021, we started reviewing our response time, getting a stroke committee where we're reviewing the cases, reviewing our response, how fast we get patient transferred to another facility if it's needed, because it's also part of the care. And next slide. So in a medical history of the stroke patients, the higher percentage was the chronic disease is hypertension. Diabetes actually along the stroke patient is decreasing, but increasing amount the patient who has the history of dyslipidemia.
Explain what that is, please.
It's increasing the chance that the artery is going to be blocked.
Are you understanding that?
Maybe.
Dr. Chang could maybe answer that.
Well, you have, we're talking about all the different cholesterol and all that stuff, the mix. And if you have a high or low HDL and such, that it's a dyslipidemia. So it just increases your risk factor for stroke based on the composition of basically your blood.
It's sort of the fats.
In the next slide, from the risk factors, smoker is the high risk. Well, it's showing from our patients, Lake Health District, what we've been seeing and taking care of in the last 10 years. And in the last 2 years, we see increase of the drug and alcohol abuse. We have the patients who have the stroke after overdose.
Do you differentiate between alcohol and the other?
No,
drugs?
we can, I can separate it. It's like a joint report, so I can't actually look back from the drug or separate the drug. And I can separate the amount of cigarettes for the smoker smoking. So I can see the difference between smoking 1 cigarette a day or the whole package.
You can or cannot.
I cannot. I would like to see the difference.
Or chewing.
Or chewing, I can see it's just like the report of the smoker. Yeah. So this is the one of the important quality report, and what we were looking and working on improve is the moment when patient arrived to facility and the time when we initiate the CT scan. It's order timing frame, and we improving this since 2019, and now we get our average time in 2022 is 22 minutes.
So what changed in 2019 that caused it to go?
Our emergency department staff started paying attention, and we have Abigail Pinetti, who was pushing forward the stroke care, and it's her work.
And a big part is the EMS service.
Yes.
Well, that's a great improvement.
Yeah, it's percentage of the patients who get there. I mean, there is always can be a lack of time.
So when the ambulance can arrive faster?
With the ambulance, actually, time to initiate the brain image was 14 minutes. So it's like almost twice faster. I mean, we improve our time when the patient arrived on the private vehicle, but our time with EMS is really incredible. And I want to say that we started looking on the time, actually, the day of the week when they arrived. stroke patient arrived. And we noticed that 56% of our, this year, patient arrived on weekends. The highest rate on Saturday.
On those 2 days?
Yes.
Saturday's 42.
42 from all these cases this year was arrived on Saturday. I mean, it's expected, patient feeling bad on Friday evening, he think that he can handle it, he taking the pills, and they arriving either 6 a.m., 8 a.m., 11 a.m. Saturday. When the important time is actually losing.
Is there any social relationship between the spike on Saturday and the alcohol, drugs?
I would say that yes,
on the Friday night
because
before?
some of the, yes, but it can be related.
Yeah.
But I think yes.
There's a correlation, but no proof.
No.
The key part that you have to keep in mind, that one of the reasons why we're focusing so much on it, number one, it's a huge issue. But number two, how do we get our team all working together to get that CT scan done as quickly as possible? And that's a big part of this, is the process for caring for the patient. Once they are identified, are we doing it the best that we can? Are we improving our process?
Yes.
Let's
And
differentiate between a bleed and a blockage, right? Whether you give the, what, Coumadin or not?
TPA. Next slide.
yeah, next slide. And why we talking about the, no matter how hard we're gonna work on improving our response time, it is important for the patient to be arriving as soon as possible from last known well. And by the information from American Heart Association, 75% of the stroke victims have dysfunction and disability, up to 30%. And the important time is 3 hours, 180 minutes. Here we're showing how our last known well, average of last known well for the Lake Health District patients was changing in a time. And actually last year we have a really good timing. I think because it was EMS service who was actually arrived quicker, so it's helped us lower average of the last known well. There was a different patient.
So the lower the bar.
Is the higher
better.
chance that it will be less disability and the quicker respond and better, better chance to lower disability
Yeah.
in the future. And now we ready to go on plan, next slide. Now we're ready to go. Organized stroke system require public awareness. So now we're ready to go to more like community education and in awareness of the patient of the stroke symptoms and using all our resources and especially EMS service if they think that they have a stroke to increase, to help them to get a better care and the higher chance not to get a disability at the end. Because the stroke is really decrease the quality of the life. And if you don't get help in the right time.
Yeah.
Now, on the aspect of getting help, you have the EMS retrieve patient in here. And the treatment actually begins when they get here, but does the EMS have some treatment that facilitates?
The EMS can quicker inform the emergency department of activation the stroke code, so all the team is arriving at the time. I can't say about EMS quick, but EMS is get confirmed the stroke. They have an attested, like, not testing,
They're assessing the
assessing
patient
the patient and inform the ED about the
symptoms.
and getting ready. Because technically EMS can't make
Right.
huge help. It's about how to diagnose, how fast you diagnose the stroke. Is helpful.
One of the things that we started tracking is if the first responders that are on site right away, now, the patient, just family member drives in, and first responders are there. But if the first responder identifies some of the classics or the symptoms of stroke, and they call the team to come in, they activate the team, we track how many times they were mistaken. We track how quickly that's called. And then that causes the team to get ready. And if it's in the middle of the night or if it's on a weekend, you have to get the CT scanner warmed up. So that the sooner you can activate the team, get them coming in, get all that going, the quicker from when they arrive in the emergency room to when they can get the care they need, that's important.
Yep.
So every minute counts.
So the superior call the team, the EMS first, and not take someone in yourself.
We had one patient,
Is that
and
what you're
the perfect case is EMS. We had only one patient who was calling ahead in ID. The daughter was calling ahead and saying, I think there is a stroke, there is a symptom. She was aware of the symptom. And when she called and brought, the team was ready. But it's one case from.
Okay.
So yeah, EMS is the best choice. But also recognize and know the symptoms and understand for the family, especially for the older people.
To answer your question, if it's within the community, within the town or very close, then calling EMS right away is often faster. But if you're in Paisley, or if you're in Adel, it may take longer to drive out and come back than get somebody on the way in as quickly as possible from last known well. And do you want to define what that means, Tori? Last known well?
The last known well time is the last time the patient or the family noticed that the patient was acting their normal self. So sometimes a patient might go to bed fine, and then the family notices the next morning that they're not acting right, or they're less responsive, something of that nature. Or the patient might say, I started getting a headache and feeling weak 30 minutes ago. So the last known well time is the point at which the clock starts, essentially. for
It
getting
sounds like the
treatment.
stroke is all about speed,
It is speed, yeah, absolutely.
getting
That's,
out fast.
that's time, it's abbreviation fast.
Do you have many false calls, like Bell's palsy or something like that? Somebody's face is drooping and,
There's a degree of that, but, I mean, it's better to rule out a stroke and have a false alarm than hesitate. So I think, in my opinion, it's better to go full bore and make sure you've covered all your bases.
Yeah.
Yeah.
On timing, if the family drives them here, that's one thing. I'm thinking about the outlying communities,
Yeah.
not so much here. Do we have a good record of the EMS meeting the family along the highway to make it quicker?
I wouldn't say
I
we
don't
need
know
to,
that we need-
it's a good question.
Yeah.
We can talk about this next time,
Yeah.
but I don't think that we have this. But I wouldn't be sure, 100%. But it's a good question.
Yeah, I figured it'd be just a hit or miss, but
Yeah.
if that could be enhanced through public information or something, it's just a little bit quicker that the EMS is there, halfway. Or
Be good for
Paisley,
us to
Summer
talk
Lake,
about.
Adel,
Yeah.
whatever.
Next. Thank you for your time.
Thank you.
thank you. Jocelyn.
It's pretty amazing what, as the team is working on this, and Elena has been gathering data, and of course Abby has been working on this too. I mean, there's a lot of people involved, but as Elena has worked on this, you can see how impactful it can be.
And our major goal is become a stroke-ready facility, and it's require 100% meeting the quality measure. That's why we're reviewing all the cases. We're reviewing the timing, why it was later, what happens. And with Dr. Gallagher, we talk about how we can improve it, what can be done different. So we are looking to become a stroke-ready facility.
Excellent.
Good.
The concept of teamwork shows.
Yeah.
Very important, yeah.
Okay. Medical staff report.
I guess that's me.
That's you, you're up.
Well, the only thing I have to report is that we had a great visit with Dr. Grace Wong, who came in, family practice OB. She's interested, just there's some things with timing for her. And you know, it'd be great to get her.
Is that OB Pacific or greater?
She's a family practitioner.
Family practitioner,
Yeah,
but
that's
also
OB.
does OB.
Yes.
Okay.
And the little ER as well.
Yes, and 20 years experience too, it's not a newbie.
That'd be great.
What is your relationship to, how do you know Dr. Wong?
Oh, I knew her from med school, and so at one point, she's in Sitka, Alaska right now. So I was actually looking there to work, and we met up and then kind of kept in contact, and then, well, it turns out it's the other way around.
Anything else? No new vetting procedures?
We thought we were going to have a clinician ready for approval for their privileges, but we're not quite ready for that yet. It'll be next month. It's class, joint class. So do we one? Oh, we didn't have one.
Okay, thank you, Dr. Chang. Tori, nursing report, you're up.
Thank you. We are coming to the end of several of our contract employees. We're losing 6 as of the 18th of September. And so we've put out our schedule for that time frame, and I am happy to report that our staff have made a real effort to pick up extra shifts. So while we're looking at being short around 1 nurse a shift, I think this is manageable and will require a little stretch for our staff with the increased volume, both in acute and OB and ER. But it is doable. I think 1 nurse down a shift is manageable, and I'm so thankful that our staff is willing to fill in the gaps and ready to take on this challenge.
On the contract employees that have left, did we pick up any that might want to stay?
I've got 1 who is wanting to stay, so, and she'll stay full-time, which is a huge win, so,
Great.
yeah.
So
real happy.
in the last couple of weeks, how full has acute been?
Acute's been around, I would say around 12 average for the last few weeks. We're holding steady at around half a dozen swing beds. And then we've had some inpatients who are still not well enough to qualify for swing bed status, but they've been here a little while. So I think right now, when I left the floor at 6:30 this evening, we had 10 patients. 9 of them have been there for several days now, and probably will be here through, I think we have 1 leaving tomorrow, but several will be here at least through the weekend into next week.
We have quite an increase in ER in the number of patients. Is there any specific reason, or is it just catch as catch can?
Yeah, I've noticed that, and I can't say that there is anything that seems to be spurring that on. COVID has been incredibly low to non-existent, and it's not seeming to be specifically injury related or weather related or anything like that. But the volume has been a nice boost, so. And full moon must be lasting 30 days these days.
Well,
Yeah, so we're keeping busy. Lots of babies too.
That's good.
Lots of babies.
Yep.
So,
on our staff, lead stretch kind of thin. give them every break they can to be relaxed. But
Absolutely.
We value them and we value their dedication.
Yes, yes. We're gonna have a recruitment booth at the fair this weekend as well. So for a lot of different positions throughout the hospital, but also for nursing and nurses' aides. So looking forward to that. That's what I've got.
Okay, no, it's a nice bright spot, thank you,
Thank
appreciate
you.
it. Tell the rest of your staff, well done.
They will. We appreciate you.
Okay, Lisa, clinic report.
Oh, so we have a lot of moving pieces right now. And I think as far as the uptick in emergency room visits, it may be related to not enough providers to see the patients. The number of patients we have. I don't know what the diagnoses are when they come in, but for a while there, it was they wanted refills on their medications, or I mean, just things that aren't typically ER related.
But you're running the walk-in on Saturdays as well now, aren't you?
We did not have it this month,
Oh,
but
okay.
we're hoping, it's
That's
just
in
due to
that.
schedules. I mean, we're hoping to get a regular, once we get more.
August vacations?
That was part of it, and we just need more staff. I mean, when they work 5 days and they're seeing a number of patients, by the end of the day, it's pretty,
Okay,
they're pretty worn out, so.
that could explain the ER as well.
Yes, that's an excellent point.
Yep, so, right now, our walk-ins are down a little bit, I think just because of the summer vacations and whatnot. I anticipate that once flu season hits and whatever other bug arrives, our numbers will go up again. We're down 3 MAs currently, we're trying to recruit, as Tori said, we'll be at the fair, hoping to hire a few more MAs. We're also looking at training them. I'm looking at a medical terminology class because often our MAs are brought in without any medical experience, and we train them from the ground up. That's just the pool that we have to choose from. And through the Certified Nurse Association, the Medical Association, they are offering a medical terminology class. So we're going to sign.
Isn't the high school here offering medical terminology? I know Bobby Stenner used to run that.
I do not know, but I can look into that.
They do.
They do, okay.
They continue that program.
Right.
But they still have lots of things to learn.
Oh, sure.
Yep, and in exchange with that, I'm hoping that we can create scribe positions to help the providers become more proficient and increase the number of patients they see. So there's a method to my madness, and I think it'll work.
Just for the public who we work for, acronyms like MA stands for,
Medical assistant. So all of
I
our
knew that,
providers
I
have
just-
medical assistants.
always like for our audience to know what we're talking.
Thanks for the reminder. We have pulmonology starting next month, September 8th, in the specialty clinic. Dr. Tamariz will be seeing patients via telehealth. So we are going to start with one patient and to use that patient as kind of a test, and then expand to probably 4 patients an hour unless it's a first-time patient, and that will be a half an hour. So any follow-ups?
But that's through telehealth only.
It is through telehealth only. But that's a better service than we have now, and saves the patient a trip to, Klamath or Bend or wherever.
Right.
So we're gonna try that out. We're excited to start that. We are losing another behavioral health nurse practitioner, but she has agreed to stay on via telehealth, which will be a huge benefit to the community and to the patient panel she has currently. So that work is in process right now. She is done now, anticipates starting again with us in mid-September from Illinois. So it's advantageous for us to take advantage of it because she already has her Oregon license and she is familiar with the patients. So we'll be able
Are
to
there
continue.
any technical shortfalls or impedance on telehealth, like bandwidth capacity or reaching out to extreme areas of the county and so forth?
We will see. I am recommending a program called DoxyMe, I'm familiar with it from the last place of employment I was, and we did not have any trouble. Stephen is on top of this, and he's going to make sure that we have the capacity we need.
I can address that. The software that Lisa's talking about, yeah, that works really well, and it is HIPAA compliant. Your question about outlying areas, is there adequate bandwidth? They have adequate bandwidth here. And generally speaking, the clients are coming to the hospital. They're going into a room. They're not getting care at home. Now, some places, they may have a mental health visit at home or in a store or a cafe or something like that. But right now, we are asking them to come in. So we're not dealing with that impediment.
Right, it is an option though, and that it was created, telehealth was created for a rural health situation. So we'll do the best we can. We would rather have them come in and then we're able to take their vitals and room them and weight and height so that when they're prescribed meds, they're accurate. But if they just can't do it, if they don't have a ride, don't have gas money, that's what telehealth was created for. So we'll try.
A little harder to be HIPAA compliant if somebody's in a cafe.
But our program is HIPAA compliant. If they choose not to be, that's not something we can control.
Within the next,
Do the rectal exam.
Don't give any ideas.
within the next decade, we'll have that better connection out to outlying areas.
And the last point that I want to make, I think that we moved 2 dedicated billers to the clinic. And I think that is helping tremendously with us being able to increase our revenue capture. They report directly to me, but we work in conjunction with Blonda and her revenue cycle team and Ed, so.
Did that just happen?
That just happened, well, Carol came on board a month ago and Mary Ann moved about 6 weeks ago.
So about a month.
Okay. So we should see the log jam dissolve
Yes.
or lessen.
There's such optimistic language here.
No, I'm not here to fail, so.
We're dissolving that clock with the human bit. Okay. Any other questions?
Thank you.
Thank you, Lisa.
You're welcome.
Okay, CEO report, Mr. Twait.
We have a couple things going on. We are going to be entering into our 3rd round of negotiations with the Oregon Nurses Association sometime either the end of September or first part of October. We've not finalized our agreement, so we're working on dates. We didn't have that set up yet, so hopefully that will be soon. Just this week, I received the second tranche of, our county's tranche of the monies from the state. So the state legislature allocated $200 million for mental health services. The first $100 million was for each county to have, they call it a BHRN, Behavioral Health Resource Network. And the second tranche of $100 million is for mental health and housing. So the first component, some of this is supported by the pot tax dollars. Some of this money from that was allocated from the general fund. As Ed said, we got a little over $500,000 toward the initial component of the BHRN, Behavioral Health Resource Network. We have to spend, the amount is about $1.2 million. The second tranche is for us is $1,487,000. So it's a lot of money. Total of a little over $2.5 million. Second tranche is geared specifically towards supportive housing. And much of this money we have to spend before the end of December 2023. So we have lots of work to do toward it. The state is fully aware that the money that was allocated to the mental health contracting entity in each county, and for us, that is the CMHP, Community Mental Health Plan, which, if you recall, that's the part we contracted with the county to manage. Mental health services are in the mental health business, not in the housing business. So this is kind of a stretch for everybody to figure out, how do we get housing, how do we get buildings, and how do we set these things up. But the need in the state is enormous, and so they're working with us, and we're working with them to try and put together a plan. We have a fair amount of this money we're going to be using toward planning. So we're not just going to go out and buy something and try to figure out what we're going to do. We're trying to do this stuff and engage lots of different agencies within the state or those that support the state.
So they'll allow us to buy a building.
Well, in each case, there is a fair amount of money that is to be used to buy something. In some cases, it's to maybe buy, maybe build. In some cases, it's to buy and remodel. There's a variety of different components of it. So it isn't as though we just go out willy-nilly buy something. We've got to be thoughtful about that process. So, but it's a lot of money, and what it also means is we have to put together a team that has the capacity to look at this, because this is over and above what our team normally deals with.
So this is housing people with mental health issues?
Might be. It could also be for people that are working on their journey of staying sober. And so typically supportive housing is a place where people can go to that's safe, sober, and has, sometimes people need extra help in their life so that they don't lose track and then go off, forget to take their medicine, get engaged with other risk people that help them be in risky environments. And so that's where the supportive housing comes in. Our part, as part of the mental health service, is to act in the client's best interest, act as minders, provide them safe environment. Some of it may be managed through the state designated housing authority to help manage the housing, and we help work with clients on their medical conditions or mental health conditions. So it's not an easy, it's this, it's that. At one of the meetings I was at, we talked about the definition of housing. And often people think, oh, you're talking about places for the homeless. When in fact, there's maybe close to 10 different definitions of the kinds of housing that are involved. So there's a lot of different kinds of things. It's not easy to explain all at one time. But we have this money, and now we don't have it yet. We got the first tranche. I have the agreement for the second one.
So once the housing is in, then we are providing services for the clientele that's in the housing.
Right. In some cases, the housing authority, in our case, the Klamath Lake Housing Authority, may actually manage the property. And we provide counseling services to those people that are residents of that.
Okay.
So there's a variety of different circumstances. In the BERN, the Behavioral Health Resource Network, there it specifically focuses on maybe finding a drop-in center that people can go to, sort of hang out, if you will, in a safe, sober environment. A lot of places, certainly in rural Oregon, those are hard to find. And so we want to try and make those available. So that's part of our challenge. I think I sent to you all some of the grants that we're working on. It's a complicated thing. We are in the process of looking for people to help us manage this enormous amount of work and stay on top. It's hard to find that kind of service. A couple things have been going on. In our clinic in Alturas, I received notice that Dr. Stevens, who we bought the practice from, is agreed to retire. So he will retire at the end of this month. Now, that was something that he wanted to do, and so it was a little bit of a surprise, so we're dealing with the changes that are going on there. One of the things we talked about in the past, now that we are providing ambulance service in this area, we have worked out an agreement with the company that owns Airlink to arrange to drive between here and the airport, or if they need to, so if we need to go out to the airport, pick up the crew, bring them here, pick up the patient, take them to the fixed wing facility, or fixed wing aircraft, and have them leave. And we would get reimbursement for that. That agreement came through today. Okay. So we will be able to go back and bill for the services we rendered since. Yes.
How far back?
Since we started the agreement in November. So that just came through today. John and I met with Tyson and the members of the ambulance, the emergency, disaster about the plan to deal with the ambulances that they have. As you recall, when we took over the EMS service, we had been leasing their vehicles for the last 2 years, or is it 3?
It'll be 2 years.
In the end of August. So we have worked out an agreement to purchase those vehicles from them, and we're working on finding financing. So we haven't resolved that yet, but we're working diligently. So that's a positive thing that we have resolved much of it, and that will be good. We are changing how we handle our screening in front of the hospital and the clinics. And that will be happening very quickly. We're going to go away from having the greeters that have been screening people at each of our entrances to where they'll be screened and greeted at the reception center. We will have...
What's the reception center?
So, for example, in the emergency room, that would be when the nurse comes out to check on the patient. If it's in the clinics, then it would be at the clinic check-in. That's where patients would be screened at that time. They still have to wear masks, but we won't have the badges that say I've been screened for COVID. We'll be moving away from that. So that'll be a change of how we deal with patients. Our COVID rates, as Tori said, have been quite a bit lower than other parts of the state and below 4s. Now, we're still in the lovely summer period, so this fall that may change, but right now, that's what we'll be doing. And we'll be having our position out front as a more of a host, rather than ask difficult questions. We may also have tablets where people can indicate their health condition in a less, sometimes it's not very easy to answer some of the questions, and we want to be given a plan in all terms. Lakeview Gardens had a little bit of excitement this past month. We were surveyed by the state. It's the normal, as you have heard, different surveys come and go. So we were surveyed both for Lakeview Gardens as well as the fire marshal came. And we just this week got our list of items that we need to have a plan of corrections for, and we're in the process of preparing. So that was, it's always stressful when the inspectors come and ask people for proof of that we're doing a good job. Other than that, it's been kind of slow. I think that concludes my comments.
Okay.
Does anybody have questions that I could maybe address? Or more I can elaborate on?
I have a reminder for the board.
You always forget about Susie.
Is that
I'm
Susie?
still awake here. This month's Med Staff meeting is a joint conference meeting. So don't forget, September 15th, the board will join the Med Staff at 12:30 here in the conference room.
September 15th?
Yes, sir.
Okay.
And
Thank you.
What time?
12:30.
12:30. And we'll have lunches for you guys.
on
Free
that-
lunch.
On that note, I need to make an announcement. Last spring, I helped out at the school as a substitute teacher. Substitute teaching, you can pick and choose. It's just something to do, make myself feel worthwhile. I was planning that again this fall. They had a very hard time filling some teacher slots. And with my background in biology, they asked me if I would be a science teacher. And I said, I'll hold down the place while you continue looking. I don't want to quit career. But it's going to compromise my time frame from Monday to Friday, early morning to about mid-afternoon. So like the 12:30, I will not be in there. And it's over my head because I don't have any teaching background. I have a background in biology and science, but not teaching. So it'll be up to the court until they find a teacher.
We'll pray for the students.
For the students.
What a
Actually, the
lucky
students are gonna
students.
enjoy it.
I'll set my rules first.
Okay.
Some of the teachers and parents was in yesterday, and I told every student, you teach me and I'll teach you back. It's a teamwork until I get the wagon underneath myself.
Absolutely.
Some people are braver than others.
It's, hopefully, they land a qualified. My emphasis is a new career startup because they need a career, but they haven't found anybody yet, so hopefully it's temporary.
Congratulations.
Good. Well, thank you.
A little stressful.
Well, with that, we'll adjourn to executive session under ORS 192, 660, bracketed 2, bracketed H personnel, bracketed C medical staff, bracketed E real estate, and bracketed H legal. And we'll give a 5-minute break.